Okay, we might make a start. Thanks everyone for attending this webinar. I'm very excited today to be being able to introduce Jeremy Grimshaw, who will be providing the presentation. I'll just start by acknowledging the traditional owners of the land that we're meeting on today and pay my respects to elders past, present and future. Jeremy and I are in Newcastle on Awabakal country. Also want to welcome any Aboriginal or Torres Strait Islanders with us today. A couple of housekeeping issues before we get started. This presentation will go for between 30 and 45 minutes. Please all be on mute while the presentation is underway. And then you can either enter questions as the presentation is unfolding in the chat, and I'll pick those up and ask them to Jeremy at the conclusion of his presentation, or you can raise your hand after the presentation and hopefully I'll get round to people and you can ask your questions then. So we'll get started. So I just wanted to welcome Jeremy Grimshaw from the University of Ottawa. Jeremy has been a long-term friend and mentor of mine and is really one of the founders of implementation science as a discipline. We're very lucky to have Jeremy here today to talk to us about implementation science and how it can be used to improve health services and health service outcomes. So welcome, Jeremy. Very much looking forward to your presentation.
Thanks a lot, Luke. And I'll just share my screen. And I'm delighted to be here and have this opportunity to talk with people today. To give you a bit of background, I am retiring in 284 days. Not that I am definitely counting down as we move forward. And one of the things that I've been, a number of people have asked is, okay, well, where are we in this kind of field? Where do we think we're at? And I'm, in my head trying to construct, basically a number of ideas about where we are. So I'm presenting things slightly differently today, and it's the first time you're the first audience to see this. And so I'd be interested in kind of feedback. It is still, I know a number of people on the call, and it is a relatively, 101 type talk. So I apologize for you folk, but you can ask me all the horrible questions at the end. I thought I'd start with the key actors if we're thinking about implementation. And I work in a health setting, but I think these ideas also would work in public health and health promotion, in social welfare, in education. But I want to start off with in health, the healthcare professionals provide care to patients. And you can see there's a nice little graphic there. And one of the things I wanted to start off by saying is that my experience across my career is that healthcare professionals are highly motivated to provide the best care they can to the patients that they serve. And so we might anticipate that they are actually able to provide the highest quality care. And then these are citizens of the world looking to their healthcare professionals. And I think when we see our patients expect that we are doing the best thing for them, and that we are we are up to date and we're providing the best evidence-based care that they could get. And so we have two of the key actors, highly motivated healthcare professionals, and also patients who've got certain expectations that reflect, I think, those motivations. But what we then find is repeated studies time and time again have shown there's a failure to translate research findings into clinical practice. There's a gap between what we know we should do and what we actually achieve in day-to-day care. And repeated studies have shown 30 to 40% do not get treatments of proven effectiveness, and 20 to 25% of patients get care that's not needed or is potentially ineffective. And this is a uniform finding globally. There's no healthcare system that has got this right. And even high-performing healthcare systems like Kaiser Permanente or the VA would say this is a challenge that they face. And so I think the implementation challenge is, why our healthcare professionals not able to provide the level of care that they intend to, that they're motivated to, they want to for their patients. And what can we do to sort of try and improve that as we move forward? And the fact that no healthcare system around the world has got this right suggests that implementation of evidence-based care is a fundamental challenge for healthcare systems that are trying to optimize care, outcomes, and costs. So what causes these implementation gaps? And there are many different models or frameworks, but I've been thinking about this in the last little while in terms of complexities and constraints. So one of the things we have is a constant evolving evidence base. And this was published, this famous paper was published probably over a decade ago now, and there's now likely even more trials and even more systematic reviews a day. And if you're a family practitioner or a nurse or a pharmacist or even a specialist in a fairly defined area, it is impossible for you to keep up to date with the primary literature. Many healthcare professionals, certainly of my generation, and we're still hanging around, we're not trained in how to appraise evidence, how to make sense of it. And so we are constantly identifying new ways of delivering care, new treatment options, new diagnostic tests, but we then introduce them into the world, and healthcare professionals, no matter how much time they can spend in their week trying to keep up to date literature, just can't. So that's one of our challenges. The second, I think, challenge is that we have complex patient needs. We have an increasingly aging population. We have many people have multimorbidities by the time they're certainly into their 60s and onwards. Increasingly medicine, we hear terms of things like precision medicine or personalized medicine, but what that really means is we're segmenting the patient groups down into smaller groups. And so it's not that we just give one treatment that we can apply across all groups with condition X. We'll give slightly different groups depending on the manifestations of the disease or diagnostic tests or treatments. And again, that highlights the complexity of the knowledge base. Our patients are living their day-to-day lives. Many of them have complex socioeconomic problems. And there's also the challenge of the burden of treatment. Modern medicine can do many things that is amazing, but it actually creates a burden of self-care for patients, which often, when they're trying to juggle their day-to-day lives, it becomes a challenge. So these are some of the complexities that I think are driving the implementation gap. But then there's also a number of constraints. And the first constraint is that healthcare professionals are human beings. And human beings, in our day-to-day lives, we develop habits and routines to get through the day. We can't really assess our performance well. How well are we doing compared to how we'd like to do? We have numerous heuristics and biases, which may lead us to make the wrong decision or to act in an incorrect way. And there are many influences on our behavior. If I go back 30 odd years, the assumption was that the problem was always about knowledge. And again, what we have found repeatedly is that the major problem is very rarely about knowledge, particularly for those areas of medicine where we've known what to do for many, many years. I left medical school in 1984. We knew that we should be screening patients with diabetes living with diabetes for retinopathy. And yet in my country, in my province, only 60% of patients living with diabetes actually get their eyes screened regularly, even though it's the commonest cause of preventable blindness in adulthood. So the challenge, one of the issues about the constraints is when a healthcare professional puts on their white coat or their scrubs or wraps a stethoscope around their neck, they don't stop being human beings. And so healthcare professionals develop habits and routines to get through the day. They cannot assess their performance well, and they have numerous heuristics and biases and many multiple influences on behavior. So one of the things about developing habits and routines is this is the way the human brain actually manages to get through the complexities of the day. And we actually anticipate, we talk about as clinicians become experts, they no longer have to think and reflect on practice. They'll often just be able to or they'll develop habits and routines that allow them to enact practice that works most of the time. But one of the challenges is that when you have behaviors that are habitual, it's both hard to stop them and it's hard to introduce new behaviors. And this paper here that was led by Sebastian Potthoff and Dominika Krasnacker, and Dominika's now she was in Perth, but I think she's in Melbourne now. It was an attempt to bring together people coming from both psychological and sociological disciplines to think about what we call non-reflective processes. But psychologists talked about habits. This stimulus will create this behavior. Sociologists will often talk about routines where teams together develop shared ways of working that again become semi-automatic. And in this paper, Sebastian and colleagues basically identify both or articulate more about what habits and routines are, but also what we might have to do if we want to change them. And I think for too long, we've assumed that healthcare professionals spend most of the time being reflective and thinking about what they're doing. And therefore, most of our interventions appeal to the reflective side of our decision-making process, when I would argue that healthcare professionals often are working in a more sort of the rapid processing, habitual side, and we need to think about that when we're designing interventions. In terms of assessing performance well, one of the things that human beings do is we have ways we want to interact with the world. I can't do this because we're doing this on Zoom and I can only see Beck and Meg on the 5 screens I've got. But if we were doing this face to face in an auditorium, one of my goals for the session would be that you didn't fall asleep. And I can't tell because Luke's got his screen off. He's probably in the back snoring his head off, but I just don't know. But if we were doing this face to face, I would be constantly scanning the horizon to see whether are people in general up and alert and awake, or are they starting to nod off? One of the problems, though, is when we think about our day-to-day performance, that's a kind of quite easy thing to get feedback on immediately. In many aspects of our lives, it's very hard for us to get feedback about how we perform. And because of that, it's not clear whether the audience is asleep, whether I'm providing the level of care that I would like to, whether we're getting the outcomes or the engagement that we want. And this paper at the bottom is a really nice paper by Alice Adams, but with Steve Sumerai, Jonathan Lomas, and Dennis Rostegnum from 1999. And what it looked at is it looked at papers that reported what clinicians said they do, and then what did objective measures show. And so, what they found is that in general, clinicians overestimated their performance by about 27%. And what this means is if in my head, I want to make sure that 90% of my patients have optimized treatment for their hypertension, but I'm only achieving about 60%, I'm likely to actually think that I'm much closer to the 90%. So I have very little stimulus to change. So when we overestimate our performance, it means that it doesn't motivate us to change. It allows us to think that we're doing quite well. And again, this is a fundamental human characteristic. No one on the call is in the lower 50% of drivers. We're all great drivers, but we know people who aren't very good drivers. So we're almost over-optimistic about ourselves and our performance, probably because I realized what a dreadful driver I was. I'd never get in the car and it'd destroy my life. But this is, again, part and parcel of being a human being. And the final thing to talk about is just there are many influences on behavior. As I said, when I started, in general, the assumption was that the key barrier was knowledge. This is work that Susan Mickey has done, where she tried to identify from multiple well-validated theories and constructs how many factors psychology thinks drives our behaviors. And you can see that there are 14. And yes, knowledge is a barrier. And if you don't know about something, you're unlikely to do it. But repeatedly, we found that knowledge is rarely the major barrier. You might not do something if you don't have the skills, or if in a busy clinical setting you forget to do something, or you're working in a habitual way and it omits the practice you're trying to do, if you're not able to sort of understand your environment and get support and resources to change your behaviors. You might not be able to do it because the environmental context and resources won't allow you. Hospitals are chaotic environments that often are not set up for to support professionals to deliver the care they'd like. There may be social influences. My peers don't think I should do this. And then there's a whole range of other roles down there. If I don't intend to do something, I won't. If I don't think it's my job as a nurse or a physician, then I won't do it. If I don't think this will be beneficial to my patients and or myself, I won't do it. If something makes me feel uncomfortable, I have an emotional reaction, I may not do it. And so again, one of the things that we've recognized in the last 30 years is that it's not a knowledge problem. It's a problem about being a human being with the cognitive constraints we face, and also the various drivers of our behavior we need to understand. But we also have issues around a constraint about just the environments in which people work. So this is a lovely picture from Tanzania, which I think reflects, although our hospitals might be slightly less chaotic than this, I think they are hugely chaotic. Healthcare professionals are frequently are multitasking all of the time. They're often interrupted. It could be that the workflows, say in the electronic health record, will make it harder or easier to do the right or the wrong things. And so the environment in healthcare systems really hasn't changed dramatically. I would say, certainly over the sort of 30 to 40 years I've been involved in healthcare, and it's still it often is one of the key drivers of the implementation gaps. So if you take all these into account, I would say perhaps the most remarkable finding is that the implementation gaps only occur in 30 to 40% of encounters. I sometimes say, what we ask is for healthcare professionals and teachers and social workers to be superhuman, and remarkably, they're close to it. But this is where I think we need to start thinking about implementation science and how can we start to design interventions and systems which will enable professionals to be the professionals they want and to deliver the services and care that they want. So implementation science is a scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. This was the definition that Martin Eccles and Brian Mittman came up in during in the preliminary editorial for implementation science. One of the interesting things about this early definition is it very much focused on professionals, and it really didn't talk about citizen patients also being key actors when we think about implementation. And there were a number of discussions in implementation science about whether studies that particularly focused on those actors should, were part of the scope of the journal. I would strongly argue that they are, and increasingly, as we work more and more and more with patients and citizens, my experience is that I become a lot more humble and also learn a lot more from them about the realities of day-to-day care. It's a relatively new health research field. So I've been working in this area for 34 years. I think when I started, we didn't call it implementation science. I can trace other trains of research and thought back to the mid-70s and Everett Rogers' work into the post-war period, but it's a relatively new field of health services research. It's inherently interdisciplinary, and there's no one discipline that has the skills or expertise to basically cover off what is needed. And one of the things I occasionally say is if you've got an ology in your discipline's name, then you've got something to contribute to implementation science. And the photo on the right is basically my colleagues in the Centre for Implementation Research. And across this group of people, we have people with expertise in medical education, nursing, cancer surgery, systematic reviews and measurement. Myself as a more generic implementation researcher, cognitive psychology, user-centered design and engineering, health economics, health biostatistics and design, journalology, shared decision-making, and medical sociology. And, I think we're very fortunate. We've worked together for, some of us, for over 20 years, but actually having that concentration of different disciplinary perspectives is essential. My own work is largely focused on systematic reviews and design, and then testing in cluster randomized trials of interventions. But I think there are many forms of inquiry that are needed if we want to make sense. And I think implementation science is complementary to other approaches and extends them. So I think implementation science isn't replacing quality improvement or continuing professional development or risk management, but it broadens the range of tools and perspectives that we bring to the table. From my own perspective, we've very much characterized the problem as one of changing behaviors in these complex environments. So we would argue that approaches to addressing the implementation gaps require key actors, whether they're citizens, patients, healthcare professionals, managers, who are living or working in complex environments to change their behaviors and their decisions. And this led us down a path to, in particularly focus on behavioral aspects of implementation. Now, I think it's part of the solution. I don't think it's a panacea. And I think what we've had in the last sort of 20 to 30 years are people who have focused on specific aspects of this. And I think the challenge for the next 20 years for Luke and colleagues and people on the call is starting to integrate these different levels of perspective. Some of you here will recognize the person on the right-hand side of the screen. He's Simon French, chiropractor, currently working at Macquarie University. When he was doing his PhD, we designed a theory-based intervention to try and reduce low back pain imaging and increase exercise in patients presenting to family doctors with uncomplicated back pain. And during that, the intervention design process was quite involved and rigorous. And we basically, developed this model, which is a simplified model about thinking about how to design interventions. First, identify who needs to do what differently. Secondly, what factors determine whether or not they do it? What are the barriers and enablers? Third, which strategies can be effectively used to target those factors? And fourth, how can we robustly measure the outcome? So this is a deceptively simple model. One of the issues, or one of the values of it, is that healthcare professionals and managers are very action-oriented. So they will often jump to step 3 without thinking about steps 1 and 2. And that's, I think, why service interventions may not always work, that they do not address the true, barriers to actually engaging folks. And we have a number of tools now that can be used to be helpful. So just to impress on my colleague in Ottawa, who wasn't in the our picture because his first child was being born. So we gave him a black mark for that. But he built upon work that was done in the 70s and 80s about specifying behavior, and particular sort of, we can specify behaviors according to the target, action, context, and time. What we thought from an implementation perspective is it's really important to also include the actor there. So, who is going to change their behavior, but the target also being for whom or what the action or the behavior is being performed. So that will often be patients with uncomplicated back pain, for example. And this is very helpful, I think, at the start of any project or any enterprise to try and change behavior, because it really forces people to think about the clinical environment and what needs to change. And as well as doing it, this on the right-hand side of the screen, you've got a sort of almost a single behavior approach. Often we're working with multiple professionals and linked behaviors, and you can do this for each behavior and each professional and start to talk about what the interdependencies are. And so I think getting people to really focus on what needs to change it often changes the conversation, the dialogue, and makes it much more grounded and practical. Identifying barriers and facilitators. There are a number of models that are out there. We like, and we've been using the theoretical domains framework. Susan Meek has also produced a behavior change wheel on a COM-B model, and there's also Laura Damschrader and colleagues, for example, talking about or devising CIFA and COM-A with the normalization process theory. So we're still, I think, learning what the strengths and weaknesses of these different approaches are. Why we like TDF is certainly it is a kind of comprehensive sweep about what psychology says influences our behavior. You can also, in a 30 to 45-minute interview, screen through which of these domains and what are the key beliefs that need to be changed within them. And so they start to identify targets for intervention, and you'll tend to get saturation about 13 to 15 interviews out. Some of the issues around this is while I've been in Newcastle, I've been catching it with Rob Stanton-Fisher. And one of his comments is that people will often give either social desirable responses or responses that basically make the problem outside. Healthcare professionals truly never have enough time, but it's very easy to say we don't have time and use that as a main sort of reason why you don't want to change, when really the underlying problems or beliefs are different. So this is a tool that is helpful. If you can complement this with observation or other ways of capturing data that will triangulate, I think will be helpful. And we have to critically think through what we're told and the extent to which we think it has face validity. And then it's just remember habitual behaviors. It is captured in TDF in terms of the memory, attention, decision processes, but I do think this is going to, or we're going to increasingly recognize this as being probably one of the major issues we have to face. If we then think about designing interventions, I mean, here's just a couple of things to think about when you're starting out. Diane Parker, who's one of the leading health psychologists in the UK working in patient safety, she worked with James Raisin, once said, there are three broad ways of approaching it, of intervening to change behavior and improve patient safety. One is to make system changes. These are great where you have a black and white situation. You should never put a chemotherapy cannula into a lumbar spine cannula, for example, and where there's unlikely to be unanticipated consequences. The problem is that, particularly given the complexities I talked about, in general, most of our care now is grey rather than black and white. And so it's actually, you need to really consider what the risks are if you go ahead, and can you mitigate those or monitor them. Once you get beyond system changes, then often it's about producing guidelines or guidance, advice about how to do things in your practice setting. But we know that you often people will not change their behavior for guidelines, and then you're down to more behavioral approaches. It's also worthwhile to think about the levels of interventions. So sometimes one of the challenges is thinking about what level can we operate, which is going to give us the biggest reach and the maximum effectiveness at the population level. So sometimes making a change at a federal level that will change practice across Australia by 1 or 2% is going to be much more important than making a change at one individual hospital where you might have a 10 or 15%. So often when I'm thinking about intervention, some of the issues are what levels might we need to intervene, what are the likely consequences of that, and can we do this at a higher level and get a greater reach. But we can also intervene at the state level, at the regional health authority, the healthcare organization, or the healthcare professional. We have many different ways of thinking about changing behavior. This is the ERIC taxonomy developed by Byron Powell. And you can see I cut off numbers 40 to 50 just to get on the slide. But that group has identified over 73 different interventions that could be used to try and change behavior. One of the issues around these, some of these interventions are actually just methods of delivery. So educational meetings is not, I think it's a method of delivery rather than a behavior change approach, because you can use educational meetings to provide knowledge. to build skills or build confidence in your capabilities, to change attitudes. And so, again, when we're looking at these, I think sometimes we have to distinguish between, what the behavior change delivery mechanism is, and then what the behavior change approaches are and what the contexts are. And I took the slide out, but Susan Meeke has also produced a behavior change taxonomy, which identifies 93 different approaches to behavior change. And these are sort of the minimum units of behavior change that I think of as atoms that we can use to build molecules. Or you could use the behavior change taxonomy to allow you to think through what do we want to build into the educational meetings if we want to change skills, or if we want to change perceptions about social and professional roles. The problem is that all of these solutions work some of the time, none work all of the time, and it's unclear when they do work whether they maximally improve practice, and it's also unclear when they do work whether they represent the most efficient use of scarce health quality improvement resources. So again, I think the role of implementation science is to try and increase the hit rate of these interventions, so we increase the likelihood that they're going to work, and we also try and optimize them, so we increase the likelihood that they're going to get the maximum benefit from them. And just to give you some idea about where the current literature base is, so these are Cochrane epoch or epoch-related interventions. Noah Ivers did the audit and feedback review, published in 2012. At that time, there were 140 trials. We are now we're updating this, hope to get it finished by the summer, and there's about 340 trials. What we observed across those 140 trials is you got about a 4% improvement with an interquartile range of 1 to 16%. And if you look across all of these areas, in general, you're seeing improvements of the order of 4 to 7%. In leaders might be better, but there's a much less of an evidence base there, and there's some practical issues about trying to systematically use them. But if you look at the interquartile range in particular, they all have quite a broad interquartile range. So this tells me that, for example, audit and feedback in general works, but in 25% of trials, there's little or no effect. And in 25% of the trials, there was a greater than 16% absolute improvement in care. And so the challenge for us now is not sort of to test, does audit and feedback work? We should be instead switching to, basically questions of when should we use audit and feedback? How do we optimize it to increase the likelihood that instead of getting 4%, we get 6, 8, or 10% improvement? And I think we need to. This has led, particularly in the audit and feedback space, for us to fundamentally rethink how we do research. So when we're designing intervention, this is some of you will have seen this before. Martin Eccles, who's one of the founding editors of Implementation Science, argued that in many healthcare settings, the way we design interventions follows the ISGLIAT principle, which stands for it seemed like a good idea at the time. We often bring together groups of very experienced people, and over several hours, suddenly something or an idea emerges. But it's not quite clear how that idea emerged or what the logic model was. And it's often driven by people who've got the most grey hair or the least hair. And it's not a reliable way to design good quality interventions. It builds very much upon tacit knowledge, which is good, but it often means that people will also go to their availability heuristics about what the implementation intervention should be. So I think what we need to think is that the choice of the implementation strategy should be based upon diagnostic assessment of barriers, understanding the mechanisms of action of the intervention. If the barrier is skill, why do we think this intervention is going to improve skills? Empirical evidence about the effects of interventions, and then very practical issues around resources and practicalities and logic. One of the things that we need to do is all of our interventions have certain assumptions. And I think too often we choose an intervention without sort of saying, do we think this meets the intervention? So I'm going to use audit and feedback as an example intervention for a number of the slides. And the top of this slide, you've got some feedback we used in a trial in Scotland in the late 1990s. But some of the assumptions about audit feedback is that it's salient and actionable. So healthcare professionals have to care about what you're giving feedback about. If you give them feedback on stuff that they think is trivial or not important to me, they're not going to be in any way activated or motivated to change. It also needs to be actionable. If you give them feedback on stuff that they can't change because it's hardwired into the system, you're just going to frustrate them. They need to be motivated to undertake the targeted behavior that's related to saliency. And the healthcare professionals undertaking clinical care actually receive the feedback. They trust the data collection and analysis process, and the actual targeted behavior is under their control. These may sound, very straightforward, but too often people introduce audit feedback that doesn't meet these underlying assumptions, and it's one of those reasons why potentially it fails. So whenever you're thinking about an intervention, you really should be thinking critically about why you think it would work, and what are the assumptions about its mechanism of action, and does that allow us, or does that suggest that we should go ahead or not? Though we can also learn from different sources of information. So when Noah Ivers did the review in 2012, we were able to do a relatively crude meta-regression that would suggest you got largely effective baseline compliance was low. The source was a supervisor or colleague who's provided more than once. It was delivered in both verbal and written formats, and it included both explicit targets and action plans. So if you were designing audit feedback, then basically here's something to consider that you should take forward. Now we have 340 trials, and we actually have a much more sophisticated, I think, conceptualization of feedback. And so what we hope this time is we'll actually be able to come up with more, robust and theory-linked recommendations about how to optimize feedback. My colleague, Jamie Briho, did a wonderful project with Heather Colquhoun, where they basically went out to interview 30 world experts in feedback. From many different disciplines, so education, sociology, management sciences, social psychology, organizational psychology, health psychology, and they gave them examples of feedback delivered in health, and said, how could you improve on the feedback that's given? And they came up with over 300 specific hypotheses. But we thought there were kind of probably a number of low-hanging fruits. So this paper identifies 15 low-hanging fruit that we think, again, are supported either by empirical evidence, by theory, or by basically strong face validity, and some of them still need to be tested. But again, if you're designing feedback, you should actually be thinking about this. And I'm not going to go through them. One of the ones that I really like are things like minimize cognitive load. I think particularly we often make feedback overcomplicated, and it's hard for someone to rapidly know, are they performing well or are they not performing well? My rule of thumb is, as a clinician should be able to look at a feedback report and know within less than 5 seconds whether they are performing well or not. And if they can't do that, it's going to take longer. They're going to basically put it down because they don't have the time to wade through a lot. So there's a lot of information out there, and all of these things represent decisions that when you're designing feedback, you are making, and often we've made them implicitly, we haven't thought about them. So having this list allows us to start to consider them actively, and you can't do all of them. Some of them are contradictory. So if you want to do A, you can't do C. But it allows us a way of starting to think more carefully about what we want to do and how we design intervention might be most useful. This, to some extent, is coming back to some of the risks associated with implementation strategies. It was done by Jamie Catlow, who's a surgeon doing a PhD in the UK, and he basically interviewed other surgeons about their about feedback for colonoscopy for colorectal cancer screening. And what he found were a number of concerns that were reported. There were concerns that were about gaming the system or doing things which, so you could meet the criterion even though it may not be in the patient's best interest. So one of the criteria, for example, is about how long the colonoscope basically should stay in the colon. And there were certainly, sort of from a qualitative perspective, reports of individuals who would keep the colonoscope for maybe an extra 30 seconds just so they meet the standard. So there's opportunities for gains, there's opportunities for potential harms. And I think what Jamie's paper does, which we can apply across all implementation approaches, is it challenges us to think about other potential risks or harms associated with our implementation interventions, which might lead us to think about, can we mitigate them? If we can't mitigate them and still want to do it, can we monitor them? And again, it's about forcing us to be a lot more thoughtful about our assumptions. And then one of the things that I've learned working with Holly Whitterman is, we may have wonderful interventions with great logic models, and they fail because they haven't been built from the point of view of the actors we're trying to engage with. So, thinking about design using human factors approaches, designing the way people are, not the way we think they are, and adapting systems to people rather than expecting people to adapt systems. So again, it highlights, if you like, the interdisciplinarity and the diverse skill sets to do a good job at designing interventions. For Luke, I'm almost there. In fact, I think I've got 2 or 3 slides left. So in terms of evaluation interventions, I think we need to do rigorous and ambitious, preferably cluster randomized controlled trials and well-designed quasi-experimental evaluations. And I will be talking more about this on Friday morning at the implementation conference in Sydney. But also we need to embed mixed methods around the test of effectiveness, the causal description, did A lead to B. We need to embed other types of methods that allow us to say how, why, and under what circumstances did A lead to B, which will really help us understand the likely generalizability or bounds that get put about your intervention if you're thinking about, can we go and do this elsewhere? So just going back to the French model, what you have are the 4 steps, and what you can see is we have a number of tools here, and there are different models, but there's an increasing range of tools that will help us, I think, hopefully think in a smarter way about how to design interventions that will bridge that implementation gap and ensure that patients and citizens and clients get the services that they need and hopefully improve the care they get. I think we also have to think about how we advance implementation practice, and we need to recognize we have an imperfect evidence base. So, I can't, with my hand on my heart, say that if you do this, I know it will improve practice. There's still a fair number of uncertainties, but I think we need to be bolder with our implementation practice. I would argue, for example, that audit and feedback is so well supported in the literature, and now we have increasingly good theorization of how to do it, that it should be part and parcel of how healthcare systems support healthcare professionals to do their job. We don't need further audit and feedback versus control studies. We should just be doing it. So when we're thinking about advancing implementation practice, we should use existing and emerging theories and models, use diagnostic process to understand the barriers and facilitators, and then use effective behavioral optimized implementation strategies. What this also means, though, it has implications for who are the people you want on your team, who's going to do this. How do you make sure you've got the breadth of perspectives that will support robust processes to lead to good implementation approaches? I also think we need to think about how to advance implementation science, how to address those uncertainties. And I think increasingly what we need to do, particularly as implementation practice takes off in healthcare and other settings, is develop collaborative research agenda with those service organizations and providers to help do implementation science that can advance their immediate priorities, but also can build a broader implementation science. And this fits very naturally into the learning healthcare system perspectives, but there aren't that many areas, I think, where learning healthcare systems are truly focusing on the implementation side. I strongly recognize the work of Luke and colleagues in Newcastle, where they have over many years now been able to bridge implementation practice and science in a way which I think is truly exciting and is a model for what needs to be done elsewhere. So I think that's all I wanted to say. So thank you for your attention. I'll stop sharing my slides, and I see there's some things in the chat I haven't monitored as gone forward, but Luke, shall I hand over to you to sort of direct travel?
Yes, thanks very much, Jeremy. That was a terrific presentation. And can I ask, if you're interested in asking a question, just raise your hand. I'll scroll through both the chat and the thumbnails to make sure anyone who's got their hand raised has an opportunity to ask questions. I can't see any at the moment, so I might just start with one myself, if that's okay. Jeremy, I'm interested in your views about the accessibility of implementation science to those that are responsible for implementing or adopting new practices, so our healthcare professionals. I think the French model has, so well used and so highly cited because of its simplicity. It's intuitive. It's a step-based approach. But as the complexity of implementation science becomes clearer to everyone, and the need for other disciplines or multiple disciplines with different methods need to be applied to understand it well, it can often become a bit mystic to those who are outside of implementation science or new to it as a field, and particularly those who are responsible for actually undertaking the implementation or adoption of new practices. I guess I'm just interested in your thoughts and comments about the risks of that.
So I completely agree. One of my fears for the field is that it's becoming over academic. And I think it's a real balance that we have to find between, I think as researchers, we have to go deep at times, but there's a danger that we make it, really complex. And I think our role is, what we're trying to do is develop practical tools, resources, insights that allow those people doing the implementation work to make smarter decisions. We'll never have perfect knowledge, but it's trying to make smarter decisions. And so I one of the motivating factors for, that I'm thinking about at the moment is, what do we have that might be able to be transferred into an implementation practice setting in a way that will be helpful without it being overwhelming. And I think that's a really interesting intellectual challenge. And it also then maybe challenges us to think as implementation science about how we advance the field as we move forward. One of the things I find challenging, I think the French model is great. You can make TDF very understandable to audiences. The problem is that there is, behind TDF, 120 years of psychological thought, and it almost looks too simple. It's like, I know what that means. So I can understand that without understanding the sort of fundamental conceptual stuff behind it. And for me, it actually argues for, certainly if I look at what happens in quality in my country, often people who are basically in quality teams are very experienced healthcare professionals who have fantastic knowledge of the local and our environment, but they don't necessarily have the implementation science or the interdisciplinary approach. And I think what we need to do is, I would hope, one of the things I'd like to see in the next 15 years is that increasingly those implementation teams start to become interdisciplinary. And they recognize that, we actually need to have someone with sort of behavioral change experience as well as system change experience within that. I think one of the challenges in the teams is that often people are working incredibly hard and very fast. And there is a danger that your psychologist will get turned into a generic health services researcher. So again, I think we have to think about, how do teams allow people to keep one foot in their disciplinary base, contribute to the implementation plan, and also take what they're learning from there back to their disciplinary base. So I think there's some interesting challenges. I think we should be cautious about what we push out as being ready for prime time in implementation practice. But I do think what we need to do is articulate the need for better interdisciplinary expert teams to do the implementation. Over.
Thanks, Jeremy. Another question is for those, I guess, who are entering the field of implementation science. Do you have any advice about the areas of research which you'd recommend that people explore, and those that you think might need to be done? We don't need any more of. So you mentioned audit feedback, where there's a number of hundreds of trials now that have investigated that as an implementation strategy. And I think I remember, it may not have been you, but I remember a paper many years ago saying we don't need more efficacy trials. And I think Justin, your colleague, mentioned in a paper a few years ago about retiring a particular theory. I can't remember which it was. But yeah, are there any advice or any comments about the areas of the field that might be easy things to look at, but we probably don't need to go there, and other areas that you think this is where would be a good investment of your time?
So I'll give a number of sort of high-level responses. One is, I gave the first plenary to the NIH Dissemination and Implementation Conference, and I said we need more theory but less theories. And I think there's a tendency in the field to develop my theory. And to some extent, the academic mission drives that. So for Simon French, the fact we call it the French model is probably the best thing that's happened to his career. He's a good friend, love him dearly. That's really helpful. But there seems to be a profusion of theories that are never developed or articulated to a level where you can test them, that they're falsifiable. And so I would much prefer starting with extant theory and trying to work out when they fall over than designing your new all singing or dancing theory. And the papers that the two papers that are related to what you mentioned. One is Robert West has a paper in addiction, probably in the second half of the noughties, where he said it was a trans-theoretical model, so Prochaska D20, is it time to put it to rest? And he argued that this theory was so dominant that it actually prevented thinking and creativity. And when he looked at the theory, it was theoretically not coherent. The empirical base supporting it was really not strong, didn't suggest that if you did what the theory said, it led to behavior change, and that we need to move it forward. The nice thing about that paper is that Addiction asked 10 groups around the world to respond to it, including Prochaska and DiClemente, and you get this wonderful debate. But one of the things I said at the NIH conference is we should be able to test theories to death. One of the things that I'm more on Robert West's side. There's probably people on this call who would be we are very comfortable with stages to change, but we should be able to test things to death because we learned from that. So there's an issue about thinking through how we can develop and test theory in a very robust way, so it is potentially falsifiable. The second area I alluded to, which is there's a colleague in Canada, Carol Estabrooks, Ali Hutchinson knows her well. I think Ali did her postdoc with her. When I came to Canada, Carol works in a nursing background and was very much looking at knowledge mobilization in a organizational and system level. And we had a conversation that's where we sort of said, well, I'm gonna keep going on the behavioral stuff because there's so much we don't know here. Carol's going to work up here. Some point in time, we have to start integrating those levels. And again, thinking about how we do that in a robust way. And there are different traditions of knowledge generation in these different levels, in these different disciplines. So how can we bring it together? But an organizational scientist called Sarah Birkin, for example, last time I saw her said that she was working on a TDF for organizational science. And I think that'd just be fabulous. That would just be like, wow, okay, now we can start to think about this in a multi-level way. A third area would be to get serious about context. And again, my colleague Janet Squires has been doing a major piece on conceptualization of contextual factors might be important, but there's still a huge amount of work to be done until we understand which factors are most important. We will never have you'll never expect 100% variance. But if we can get up to 30%, if we're now currently 20% with what we know, we get up to 30%, we're going to design smarter interventions. So again, I think we have to think about how we build good tests of context into work that's done. It needs more conceptualization, more measurement, but it also probably means we need to start doing studies, purposely replicating studies across different contexts. And that would be a third area. And then I think the fourth area would be, it's not really, it would be how do we build these implementation practice, research partnerships. I think they would advance science. There's one of the things is that, and you can tell me to wrap it up, with the audit feedback, what we argued is a paper by Noah Ivers, No More Business as Usual, published about 2012, is that we didn't need we needed very few new trials of audit feedback versus control. In general, we know it works. You might go, if you were going into, say, a long-term care situation or a situation with healthcare professionals or staff who've not had feedback, you might want to do some tests there. But what we need to do is move to head-to-head trials of audit feedback A versus audit feedback B. And if you look down that slide I have of the epoch reviews, across most of them, there's big bodies of evidence. We probably don't need more trials of intervention versus control from many areas. What we should be trying to do is design head-to-head trials or comparative trials to move forward on that basis. The only other thing is I did a presentation at Macquarie, and there's some small group work, and I sat at a table with someone I think probably doing their PhD, and one of the things that they said is, it's really hard because I don't want to get it wrong. And my comment to her was, you need to make sure that whatever you want to do is justifiable. But then if you find it doesn't work, we've learned something. We've contributed to the knowledge base. And again, I think sometimes you need to be bolder or, recognize that, we should anticipate when we're doing science that we will fail frequently. That's a good thing. We learn. So the final thing I'd say for a new researcher is think programmatically. Your PhD is not going to solve the world. It's going to make a very, very small contribution. And probably, what you'll do is over a 5 to 10 year period, programmatically, you're going to develop a body of expertise. If you can think smartly how to do that, then you can definitely sort of make a contribution. Over.
Right. Thanks very much, Jeremy, and thanks very much for your time today. Terrific presentation. Also want to thank Rebecca Thompson and Megan Finch for organising the event, and the National Centre of Implementation Science for hosting it. I hope you've all enjoyed it, and we'll be in touch with details of where the recording can be accessed. Thank you, everyone.